Medical Student Education Series Core Orthopedics. All about orthopedic infections, osteomyelitis and septic arthritis, Part 1. The key challenge here is to distinguish osteomyelitis from septic arthritis in the acute situation. This is very difficult for most students and young doctors. Here I will show you how to tell the difference very easily, as it has some very important implications for the management. The other concerns of the chronic situation, there's not such a great difference between the two situations. Here's a young child, toxic, unwell, won't move the arm, it's swollen and painful. Is it acute osteomyelitis or is it acute septic joint? The workup generally is ESR and white cell count will be elevated. X-ray in the acute situation won't show much, some swelling, later on sequestrums, involucrum. CT and MRI not that useful in the acute situation. Bone scan can be, but it can take several hours to get. Blood cultures will be positive in 50 to 70% of cases, but it takes several hours to come back. Biopsy is only in the chronic situation. The usual bugs are Staph aureus, but in the newborn you can get strep, E. coli. In children, some gram-negatives. Sickle cell salmonella. Treatment. This is where the difference is. Acute osteomyelitis is IV antibiotics, late orals. Only surgery when the condition is worsening to relieve the pus or the dead bone. Then you simply curette it. The simple Voltman's curette will remove the soft bone. Acute septic arthritis, this is different. You must take the patient immediately to the operating room to wash out all the destructive organisms which are quickly destroying the joint. You start at the same time general antibiotics until the correct organism is identified. So acute osteomyelitis, mainly IV antibiotics, hydration. Acute septic arthritis, wash out in the operating room along with your antibiotics. So back to our clinical situation. Child toxic, unwell, arm painful and swollen with the septic joint, will not move the elbow at all, pseudo-paralysis. With infection at the end of the bone, will move it even though there's sympathetic effusion. So this is a septic joint, red, swollen, tender, won't move. To the operating room immediately to save the joint. Post washout, child starts moving the arm very quickly. Chronic situation. Chronic osteomyelitis occurs after poorly treated acute case, immunosuppressed. Staph aureus, various organisms. There are classification systems available. Can be subacute, between acute and chronic. Epiphyseal when it's in the end. A treatment of chronic osteomyelitis, chronic septic joint, mainly choosing the correct antibiotics based on your infectious disease specialist working with you in a team. Surgical debridement, get rid of the dead tissue. Later reconstruction, bone grafting, stabilization, soft tissue cover. Amputations may be necessary to get rid of a painful chronic limb. Chronic septic joint, major challenge, correct antibiotic as above. You may need to do a surgical arthrodesis or joint replacement when the infection's quiescent. These are highly specialized cases requiring orthopedic surgeons who have a subspecialty interest in this area. In general, septic arthritis, you can read this at your leisure, can be hematogenous, bacterial love, articular cervices. You get septic hip in child and knee in children, infants there. TB, don't forget it. Haemophilus influenzae in children under 5. Staph infections in children greater than 5. Gonococcal in sexually active adults. We like to say heal with steel for dealing with a septic joint. Other cases of acute septic arthritis. A young female, Crohn's disease. The steroids have killed the femoral head, avascular necrosis. Associated with Crohn's disease is an infection in the joint. Painful, stiff, pseudoparalysis, won't move. Wash the joint out, get the correct antibiotics. A young child, age 6, painful ankle, minor trauma. Get to theatre, wash it out, start antibiotics, then soon identify the correct organism. We will next move on to part 2 in another video.